All right, so welcome everybody to Buy Me 590. It's my pleasure to introduce Dr. Sarah Biber, who is the Executive Director of the National Alzheimer's Coordinating Center. And she's going to be talking today about the key role that informatics plays and some informatics opportunities and challenges in this environment. So with that, I'll turn it over to you, Sarah.
Okay, thank you. Thank you, Peter, for inviting me to join. If you guys might want to crank up the volume on your computers, as he mentioned, I'm hoping my voice will last till the end of this presentation. I'm unfortunately still recovering from COVID, and I'm going to have to talk pretty softly today, which is not my usual way of talking for people who know me. Thank you, Peter, for inviting me to join. It's wonderful to be here to share my work, which is focused on building informatics solutions to advance Alzheimer's disease and translation. Oh, how do I do next slide? Great. Before I get started with my talk, I wanted to mention that everything I'm going to share with you today was made possible by the incredible team at NAC. I want to thank the NAC team for teaming up to accomplish this important work together. I also want to give a special shout out to Sean Mooney, who couldn't be there here today, but said he was going to listen to this recording later, who has been an important thought partner in envisioning our new modern NAC data platform. So I have followed an unconventional path to bioinformatics. My career trajectory has taken me from a PhD in molecular and cellular biology through a range of leadership roles in the healthcare, research, and innovation sectors at the national, state, national, and large healthcare institution level over the past 10 years. That is, in fact, a picture of me at 1 week old. Throughout my career, I've had a strong focus on team science, implementation science, leading strategy for complex programs, developing and translating biomedical innovations, and building national informatics infrastructure to advance research and discovery. My primary innovation focus roles included serving as the program director at the Oregon Bioscience Incubator, a startup incubator and economic development organization that's funded by the state of Oregon. And secondly, launching and leading the surgical innovation program for Oregon Health and Science University. I have held 2 leadership roles at National Informatics Coordinating Centers focused on building major informatics research infrastructure, capacity, and innovative tools. In addition to my role at NAC, I also served as the assistant director at NIH's National Center for Data to Health, which later became the National COVID Cohort Collaborative, N3C. I believe that my non-traditional academic route to bioinformatics gives me a unique perspective on the collaboration, innovation, infrastructure, and team science that is required to create robust research informatics systems that rely on strategic partnerships, complex governance solutions, data standardization, and also harmonization. So advances in cyber infrastructure are having a transformative impact on how we do science in bioinformatics. Traditionally, graduate students have done small-scale siloed data collection and written up papers in isolation, been there and done that. Modern cyber infrastructure is empowering a new generation of researchers in their quest to unravel complex diseases. It's having a transformative impact on how we do science and what data we can use to do it. So it facilitates easier collaboration across academia, healthcare systems, and industry. It's been providing access to unprecedented amounts of data.
What kind of software? It is called Inform, which is
Somebody
patented AI-based system for them to sort of do phenotype-based.
Somebody mute themselves, please. Thank you. It has provided access to unprecedented amounts of data and to new tools for computational and data-intensive research. So cyber infrastructure is most impactful when data is standardized, there's a broad data integration and interoperability across ecosystems, and when global cloud infrastructure can be leveraged to accelerate and amplify collaborative research and translation. So cyber infrastructure is also enabling adoption of more open data through fair guiding principles. Over the past 2 years, I have been funded by NIH to modernize NAC and establish expanded interoperability with other big NIH-funded data repositories. In my talk today, I will introduce you some of the current key challenges and opportunities in Alzheimer's disease and related dementia research. I will try to convince you that now is the perfect time to become an ADRD researcher and illustrate how NAC data can empower you to shed light on the most pressing questions in ADRD. I will also highlight some of the exciting bioinformatics challenges that I've been tackling with my team over the past couple of years and the impact this has had on the ADRD field. This will include examples of how we are advancing ADRD research through data standardization and harmonization, developing implementation models to drive informatics modernization across large consortiums, building cyber infrastructure to expand interoperability, and enable multimodal data integration, harmonization, and sharing to gain insights in complex disease, as well as enabling the generation of real-world evidence in ADRD through the integration of real-world data. So you'll hear me talk a lot today about Alzheimer's disease and related dementia, or ADRD, as we call it. The reason for that is because most people who have dementia have more than one underlying disease causing their cognitive symptoms. Therefore, we like to think of this as a suite of conditions that we are studying and refer them to it as ADRD. Okay, next slide. So what are some of the key Alzheimer's disease challenges and opportunities? Well, first, I'll start off by saying, as many of you probably know, AD is a widespread and lethal disease that an estimated 6.5 million Americans are currently living with. Everyone here likely knows someone, unfortunately, who has been or will be affected by this disease. And Alzheimer's disease progresses along a continuum from normal cognition to mild cognitive impairment to worsening dementia symptoms. This is an incredibly exciting time in Alzheimer's research. For the first time in decades, there are drugs coming on the market that convincingly slow progression of disease and more that are on the horizon. So with this project, this progress and potential promise comes an even more urgent need to effectively tackle the most pressing challenges in Alzheimer's research. I'm going to take a few minutes to outline what I see as some of the key challenges in the field right now. Later in the talk, I will highlight how NAC data can be a valuable tool for tackling the most pressing scientific challenges and gaining critical insights into this incredibly complex disease. So robust and accessible early detection is a critical need in the field right now. With Alzheimer's disease, biomarker changes, those can be detected via brain imaging, CSF, or blood, are evident 15 to 20 years before neuronal damage and cognitive symptoms occur. So this window before symptom onset provides an important opportunity for testing clinical interventions and delivering new and emerging disease-modifying therapies that can prevent or slow the progression of cognitive symptoms. AI has shown promise for advancing early detection, and I'll mention a little bit more about that later in my talk. Most people who have dementia symptoms have more, as I mentioned, have more than one underlying disease contributing to their cognitive symptoms. This is known as mixed pathology dementia. Developing methods to disentangle that heterogeneity is absolutely critical for advancing the field. This is important for accurate diagnosis and prognosis, and for the development of and delivery of tailored therapies to treat all underlying diseases that are contributing to a patient's dementia symptoms. Blood biomarkers are becoming an increasingly valuable and affordable tool for early detection and staging of Alzheimer's disease. There is an urgent need to further validate and assess the sensitivity of these biomarkers and to develop new biomarker standards that can be effective and biomarkers that can effectively detect other underlying etiologies that contribute to dementia symptoms. Numerous factors contribute to and modify the onset and progression of AD pathophysiology, physiological changes and symptoms. We need to be able to understand contributions of modifiable factors to resilience, to be able to identify and stratify risk factors and protective mechanisms to better predict individual disease progression, and so that we can also potentially delay or prevent AD onset or progression. ADRD is complex and also varies by patient. So robust precision medicine strategies will allow us to take genetics, environment, and lifestyle of a person into account to be able to select targeted treatments that could work best for patients. And by expanding data collection integration, we'll also be able to pave the way for using precision medicine for large-scale population-based screening for early diagnosis of ADRD and comprehensive assessment at a population level of ADRD risk factors. Lastly, population-based dementia-related health disparities exist based on race and ethnicity, sex, education, and socioeconomic status. So including diverse participants in clinical studies is absolutely critical to ensure the generalizability of findings. This will ensure that we can have effective early detection, identify modifiable risk factors, and develop therapeutics for all populations. Absolutely, it's a challenge in the field right now and one that we absolutely need to address. So I'm going to give a quick introduction to NAC as well. So NAC serves as the data collaboration and communication hub and centralized data repository for NIA's ADRC program. There are currently 33 ADRCs and 4 exploratory centers spread across 26 states. NAC manages one of the largest and most comprehensive longitudinal standardized clinical neuropathological data sets in the world. So we currently have data, on more than 50,000 participants. We have about 60% of our participants who pass away are brain donors. We have almost 8,000 neuropathology data sets. A lot of people are using and publishing with our data, and that number, of course, is increasing. I'll show some more data on that later on. And so I want to tell you just a little bit about how that works. So like I said, there are 37 centers around the country. These centers all collect standardized longitudinal data. They enroll research participants who are healthy, at risk, or with dementia symptoms. We do have a lot of controls in our database. That's something some people don't realize. And then centers collect standardized longitudinal data through annual visits using tools collected and developed and provided by NAC. So we have up to 18 years of data on some of these participants. Over the past 2 decades, NAC has been focused on collecting, harmonizing, integrating, and sharing this ADRC data. And there's some things that are pretty special about this data. It's an incredibly unique data set. So the uniform data set, which is one of the primary types of data that we collect, includes rich multi-domain or cognitive, clinical, and phenotypic data. It has robust criteria-based diagnoses, which are considered gold standard across the field and often used to ground other studies, as well as phenotypic data that supports genomic analyses, data captured for participants prior to and post-dementia onset. And we also have the infrastructure in place, as I mentioned, for ongoing participant tracking. We have a large quantity of neuropathology data for diverse etiologies, so both the pure etiologies like pure AD, as well as mixed AD, as well as other types of underlying etiologies that cause dementia, like Parkinson's, et cetera. We also have a large quantity of heterogeneous MRI and PET data. So let me keep going. I need to take a little water, apologies. Okay. So next, I'm going to get into the informatics challenges that I'm tackling in ADRD, starting with my work to advance ADRD research, so data standardization, harmonization. So NAC has always been fair. And one of the fairest aspects of NAC is that we set clinical research data standards for the field. This means that all ADRCs collect data in the same way, using the same instruments so that the data is standardized before it is submitted to NAC. To accomplish this, we convene leading experts from across the country every few years through our clinical task force to define the latest clinical research standards. This includes co-developing tools to collect and ensure quality control for this data. So I've been overseeing a collaboration with the clinical task force over the past couple of years to develop and launch and test the latest version of our uniform data set called UDS v4. So NAC UDS tools are used by ADRCs, but they've also been translated into dozens of other languages and are used widely in international research studies focused on ADRD. Making regular updates to our standardized UDS instruments is important for ensuring that we can stay aligned with rapid advances in ADRD science and our evolving understanding of best clinical practices. For example, UDS v4, which is set to launch this spring, will capture data on the use of disease-modifying drugs using the RX norm ontology, which will be important for tracking outcomes. Additionally, it will collect in-depth data on social determinants of health, which have important impacts on disease, risk, and outcomes, as well as add new scientific concepts and use terms that are more inclusive of gender and racial identity. So we're off to a good start with FAIR, but we can do even better. Over the past 2 years, I've been leading efforts to make NAC even more fair. I'm going to share a little bit about that. Under my leadership, NAC is undergoing massive bioinformatics infrastructure modernization that is aimed at putting us on the leading edge of NII's new data science strategy and FAIR innovation. So this includes, I already talked to you about the modernization that's happening with regards to the content that we collect, but this modernization also includes a modern streamlined electronic data capture system powered by REDCap, a modern data platform that's easily scalable to new data streams, and to building linkages with other data repositories, and an advanced data search and access portal. A common theme that I apply to all of these initiatives is that we do not want to build it and hope that people come. All these new tools that I mentioned are being iteratively developed in collaboration with key stakeholders across the ADRC program, with the goal of meeting the growing needs of the research community. So you'll see who some of our partners are up there in these top boxes: EDC Work Group, ADRC Steering Committees, NIGADs, ADRCs, and I'll tell you more about some of that. So I'm interested in developing strategies and implementation models that are going to incentivize and enable consortiums of heterogeneous organizations to adopt new informatics standards and systems. So these strategies and models are absolutely critical tools for driving modernization, and that is essential for accelerating translational science and advancing ADRD discovery. So the approach that I've taken to building a modern electronic data capture system is a great example of this. So transitioning an entire consortium to electronic data capture is a perfect example of what I like to call a socio-technical informatics challenge. So the technical side of the challenge involves building informatics pipelines to collect, integrate, and QC the data. The social side of the challenge requires incentivizing and enabling a large heterogeneous consortium to all quickly start collecting and submitting data using the same rigorous protocols and standards. So when I first arrived at NAC, the ADRC program was using a data submission system that was 20 years old and needed to be updated to become more cloud-friendly and virtualized. And the ADRCs were literally doing data collection 37 different ways. In order to tackle this challenge, I teamed up with the ADRC Data Core Steering Committee and my colleague Sudeshna Das from Harvard to launch and co-lead an electronic data capture work group in January of 2022. Sudeshna and I have since grown this group to 91 members across 32 ADRCs that are actively collaborating across 3 subgroups focused on requirements, co-developing forums, and documentation and training. The primary goal of the implementation model that we developed and deployed as a framework for this work group was to co-build and drive adoption of a new streamlined and scalable modern electronic EDC system that was powered by REDCap for the ADRC program. We're also seeking to foster more collaborative software development, build a data community across NAC and the ADRCs, promote and share best practices, and to make data-driven decisions using surveys and interactive workshops. We decided to start with REDCap because 20 centers were already using it for forms data capture. And here you can see how we're going to be using REDCap to enable collection for UDS v4. We have 3 different mechanisms for that, including direct data entry into REDCap, NAC REDCap, by synchronizing local ADRC REDCap instances through REDCap APIs, and also allowing some bulk upload of CSV files using REDCap. So the new REDCap-based EDC system that we have built for UDS v4 is set to launch in the spring of 2024 and greatly streamlines and reduces burdens with features like autofill and skip logic, automatic EHR to REDCap extractions, real-time error checks, and transparent and replicable QC processes that are all available via GitHub. We've also recruited leaders from across the ADRC program and champions to pilot test and champion the benefits of this new system to help increase buy-in from across the ADRC program. So a key part of my approach includes having my team track the progress of these implementation models through surveys. So far, our implementation model has resulted in 7 more ADRCs adopting REDCap. That's a 37% increase since March of 2022. And we haven't even launched the new REDCap system yet. Additionally, 10 more ADRCs, a 52% increase, have indicated that they are planning to transition to electronic data capture once our new REDCap system is launched alongside UDS-v4 this spring. So I want to give a big thanks to our EDC workgroup members, including my fellow NAC team members, some of whom are here today, who've made all of this work possible. So I'm also interested in building robust cyber infrastructure that will enable analysis across large, diverse data sets to gain a deeper understanding of complex diseases like Alzheimer's disease and related dementia, and also unlock new avenues for diagnosis, treatment, and prevention. So next, I'm going to share some examples of how I'm leading NAC to expand interoperability and enable more multimodal data integration, harmonization, and sharing. So to see here. So since joining NAC, my goal has been to reimagine and modernize our data platform to make it virtualized, scalable to new data streams, and more interoperable with other NIA-funded repositories. We recently moved, so that is here under our modernization roadmap. We recently moved to all of our existing data onto a new virtualized cloud-based multimodal data integration harmonization platform powered by Flywheel. Our platform is designed to be readily scalable to new data streams and to enable interoperability with other platforms. We're collaborating with other NIA repositories to expand interoperability between our platforms and to enable integration of metadata and analysis data for standard MRI and PET data, blood biomarker data, and genetic and genomic data, all for ADRC participants. More recently, I initiated a new collaboration with Sage Bionetworks and secured funding to build interoperability with their AD knowledge portal. So this will allow us to integrate multi-omics metadata and analysis data moving forward for ADRC participants. So this is a great example of how NAC is helping to standardize and harmonize a valuable new data stream and make it more interoperable and accessible to researchers. I'm also leading or co-leading numerous funded pilot projects focused on building new pipelines and governance processes to integrate, QC, and share new data streams directly into the NAC data platform. So I don't have time to talk to you about these today, but this includes digital data, projects focused on digital data, digital neuropathology, as well as an ongoing project focused on EHR and claims data. I'm also on the executive team and function as an MPI on a new major initiative called Clarity, which I'll cover in more detail shortly. I'll be leading efforts to expand the NAC data platform so that it can effectively serve as the informatics and infrastructure backbone for the entire Clarity initiative. Clarity will greatly amplify and accelerate standardized MRI and PET and blood biomarker data collection and processing across the ADRC program. It will also establish new pathways for advanced MRI data and digital neuropathology data collection. And those last two data streams will be coming directly into NAC. All of the Clarity data streams will be connected to NAC IDs, our unique identifier for ADRC program participants, integrated with the other NAC data streams, and made available to researchers everywhere through the NAC data front door, which I'll tell you more about. So in summary, the new NAC data platform that I've been spearheading development of is scalable to new data streams, designed for real-time data search, visualization, access, and ready for AI-driven discovery. So there's a lot that can be done and that is currently in the works to further optimize the NAC data platform for AI discovery. But I want to note that NAC data is already being used for impactful AI. And here are some examples of recent papers that illustrate that. So Vijay Kolachalama, who's a close collaborator of NAC and team, used NAC data to create a deep learning framework for accurate differential diagnosis of normal cognition, MCI, AD, as well as non-AD dementia. The model can diagnose cognitive status using MRI or non-MRI data, which includes demographic, medical history, functional assessments, and neuropsych test results. They use neuropathology data from NAC to interpret and validate their model. Narges Razavian and team built an AI model for early AD diagnosis and validated it using NAC's highly heterogeneous MRI data. We have both standardized and heterogeneous MRI data to show that it could perform well in more real-world settings. And lastly, my colleague Hiroko Dodge and team used NAC data to build a probability calculator that can be used to enrich for patients for clinical trials that are likely to undergo rapid decline, which is really important for clinical trials where we want to show that a drug can effectively change the course of the disease. So a growing number of researchers are using AI for ADRD discovery, and we want to make it even more attractive and easy for them to do that using NAC data. As I mentioned, and I talked a lot about already, I'm spearheading efforts to integrate more and more ADRD data streams into the NAC data platform. So that includes the data, metadata, and often associated analysis data. So we really hope that combining these new data streams and believe with NAC's longitudinal rich neurocognitive data and gold standard diagnoses will allow AI researchers to build new impactful AI algorithms to advance early diagnosis, patient subtyping, conversion prediction, risk stratification, and prognosis. So down the line, we also want to make this new multimodal data available to the research community via open data challenges, potentially using Sage BioNetwork's Dream Challenge framework. Excuse me, more water. Okay. Next slide. So over the past 2 years, I have secured buy-in from NIA leadership and other NIA-funded repositories for my vision to really make NAC the one-stop shop for searching and accessing all ADRC data streams. So this includes both data streams that are housed at NAC and data streams that are housed at other NIA-funded repositories. So I'm going to tell you now about the NAC Data Front Door. So we call that new advanced data search and access tool the Data Front Door. So NAC data is actually being used for impactful research all over the world, and it's freely available for all researchers. So how are we going to make this data even more easily available to researchers? So NAC is currently collaborating with other NIA-funded repositories and ADRD researchers to develop a data front door that allows data sharing through several self-service components, including a quick access file data request system, real-time dashboards, and an innovative cohort selection tool that lets researchers build their own multimodal data sets. So for our quick access file system, which is available today, it takes about 15 minutes for researchers to request NAC data and sign a data use agreement. They then get access to all of our data within 24 hours. Our new quick access file request system, which is powered by RedCrap, and was deployed in the past few years, has greatly increased data utilization, which I'll show you more data on in a moment. Our dashboards, our real-time dashboards, allow researchers to see real-time data for a variety of different data types. We recently deployed a dashboard to allow researchers to view scan imaging data, and we have more dashboards that are in the pipeline. You can access that. Oopsie. You can access that today via our website. And then our cohort selection tool, which is we are still in the process of finishing defining requirements for, will enable researchers to build their own multimodal data sets. So it will be is going to be designed to be easy to use, self-service, in real time, and will include all integrated ADRC data streams. So as an example, right, researchers will be able to use this tool to select all the participants with a specific genetic mutation that got below a certain score on specific neurocognitive exams and have a recent PET scan indicating low amyloid levels. So that's the sort of granularity we want people to be able to do with building these cohorts. I was invited to co-lead and co-organize a half-day ADRD multimodal data workshop at the Alzheimer's Association's International Conference this July. We'll be bringing together researchers to further define requirements for our data front door that we can then use to ensure that this data can be effectively used to address the most pressing challenges in the field. So this is open to anyone. You're all invited to join if you're interested in working across these data types to tackle these kinds of questions, then this would be a great workshop for you to participate in. Down the line, we also want to make it possible for researchers to create a secure enclave for data analysis where they can directly do this within the NAC AWS cloud environment. The Enclave expansion project is part of the NAC renewal for 2026, and we're interested in recruiting AI collaborators. If you know anyone like that, I think I already have plans to speak with some of the folks here today. I will be leading as part of this an AI ML subgroup starting next month that's focusing on developing funding models so that researchers can access affordable GPUs via the NAC data platform in order to be able to do this work. So I've shown you some examples of how NAC is becoming more fair. I also want to mention that we have plans to make NAC even fairer. So I want to go through this quick roadmap here and just highlight a few things. So the things in black are things that we're already doing, and the things in blue are things that we are in the process of doing or planning to do. So we are looking, I mentioned the NAC ID, which is our unique identifier for all the ADRC participants. We're also interested in looking at adopting the PPRL as another persistent identifier that will enable us to connect to other kinds of data, in particular EHR data in other repositories. I mentioned that we want to set up a secure enclave for analysis. We also want to collaborate with ontologists to incorporate more common data elements into the data that we collect. We want to make sure that our data front door allows for reproducible core selection queries, as well as part of our renewal, we are planning to transition to central IRB and a standardized e-consent using a flexible REDCap system. So, and our efforts becoming fair, I would say, are working so far. So since our new quick access data request system was updated in 2021, and along with some of the other changes in modernization of making it NAC, there has been a 102% increase in the number of data requests, average number of data requests per month, and a 23% increase in published studies using NAC data during this time. So a big focus of my work is also on building a more seamless ADRD ecosystem. We have a lot of active projects and collaborations right now focused on expanding data integration and interoperability. I only have time to focus on a few of them today, but I'd be happy to come back and talk about some of these another time if there's interest. So I'm going to start by talking about, SCAN, Clarity, and a little project that we're doing, a recent project we launched with Gates Ventures. So here we go with SCAN. So I'm going to start by talking about a project that I've been co-leading to design pipelines to collect, standardize, harmonize, and share MRI PET data, which is called the SCAN initiative. So SCAN's mission is to collect large quantities of standardized imaging data, integrate it with other data modalities that are available via NAC, and share it with researchers around the world to advance the field. So under my leadership and together with our SCAN partners, we have built a process and pipeline to collect, integrate, curate, QC, and share large quantities of standardized MRI and PET data and associated analysis data. And that analysis data includes MRI volumes, for PET includes SUVRs, for amyloid and tau. So this involved building new informatics infrastructure and designing and deploying an implementation model to incentivize, amplify, and accelerate data collection from across the ADRC program. So when I first started at NAC, SCAN participation was really low across the ADRC program and facing some significant obstacles. In order to address these challenges, I focused on identifying and addressing barriers, facilitating ADRC participation. I think someone needs to mute, supporting data quality, and providing data access. Over the past 2 years, I've effectively led NAC's successful collaboration with NAC to tackle the socio side of the SCAN challenge. So this involved establishing, as a long story, which I'd be happy to come back and tell some time, but the summary of it involves establishing new governance and developing and deploying new tools and strategies to incentivize participation and increase the ADRC program's capacity to quickly and effectively adopt new standards for MRI and PET data collection. So some examples included establishing a standard checklist powered by REDCap to guide and track progress towards SCAN readiness at each ADRC, which 100% of ADRCs reported was useful. Another thing we did was we used a live leaderboard to publicly track MRI and PET submissions from each ADRC and to incentivize their participation. Turns out folks are very incentivized by a public leaderboard to start submitting more data. We also empowered ADRCs to track and address the QC status of their own MRI PET submissions by creating and providing a real-time QC dashboard for each ADRC. So these tools and strategies have had a transformative impact on the SCAN initiative by amplifying ADRC participation and compliance, and by making the value of this data more apparent to researchers. So together, these initiatives that I mentioned have contributed to more than a 500% increase in SCAN, MRI, and PET submission over the past 2 years. You can view all the standardized MRI and PET data that's available across the ADRC program today on our website via our real-time public scan dashboard, which also serves as the leaderboard that I mentioned for ADRC participants. You can see which ADRC is winning today. And all of the scan and analysis data is actively being incorporated right now into our quick access file, and data request system available to researchers everywhere starting this April. And finally, I'm excited to share updates on our new Clarity initiative that will enable researchers to disentangle and address ADRD heterogeneity. So NAC is a critical partner on the Clarity initiative, which is a $149 million grant that was just funded. I am serving on the executive team, and I'm co-leading development of bioinformatics infrastructure that is needed to power this study. As I mentioned before, the majority of patients with dementia symptoms have multi-etiology dementia. So more than one underlying disease is causing their dementia symptoms, which really complicates diagnosis, prognosis, and treatment. So in order to advance our understanding of multi-etiology dementia and expedite the development of effective early diagnostics, precision treatments for patients, we really need to understand this better. So NAC is a valuable partner for this initiative because the ADRCs actually follow the largest multi-etiology dementia cohort with a variety of critical UDS assessments, including autopsy. And because of our ability to scale our multimodal data integration and harmonization platform to incorporate and share new data streams collected through this study. So one of the big goals of Clarity, as I mentioned, is to really gain insight into multi-etiology and build methods for being able to disentangle that etiology, as well as to standardize blood biomarker data collection and imaging biomarker data collection across the ADRC program further, so that can be used to diagnose and stage the disease in participants. So the overarching goals here for Clarity are to create individual etiological profiles using imaging, plasma, and antemortem biomarkers. Clarity will also be focused on building out a pipeline for collection of digital neuropathology data from across the ADRC program. Secondly, we want to provide resources to implement standard biomarker methods across the ADRC program so we can collect those ATN markers that I mentioned. And we also, it is focused on diverse representation for generalizable discovery. So actually one of the most powerful things about Clarity is they're actually funding a full-time position in each of the 37 ADRCs that's focused exclusively on recruiting diverse patients. So, oops, sorry, I skipped a slide. Go back. So basic for Clarity, we're anticipating a recruitable pool of 11,000 participants, and Clarity will enable imaging and blood procedures for 2,000 of those patients across at least 2 time points over the 5 years of the grant. So Clarity relies on NAC for all of its infrastructure. I'm just overlaying here. So all of this data is going to be collected, integrated, harmonized, and shared out through NAC. We'll also have a pipeline for returning results and information to both ADRCs as well as researchers everywhere. So I don't have much time to tell you about my work focused on enabling the generation of real-world evidence in ADRD through the integration of real-world data, but I do want to highlight one recent project in the space that I think is exciting. So this is a collaboration with Gates Ventures. So I am co-leading a pilot program with Gates to fund up to 3 proposals this year at $250,000 to $1 million direct costs each, which are focused on advancing ADRD research and discovery through impactful digital data collection. So we're really interested in projects that leverage digital technology to capture richer and more objective data with less burden, and or that advance the development or validation of digital biomarkers that improve early detection, diagnosis, and monitoring. So the goal of the program is to accelerate digital data collection across the ADRC program, but also beyond the ADRC program. In fact, it is open to anyone. So too late to apply now. We actually, the applications just closed in February 21, but Gates has let us know that they are interested in the idea of continuing this program with us moving forward. So that is very exciting. So we are in the process right now of sorting through these applications, more information to come soon, but we're really excited about the impact this is going to have on accelerating digital data collection across the ADRC program and beyond. So I want to return now to why NAC data. I've told you about a lot of problems and challenges in the field. So why is NAC data a critical resource for being able to address the most pressing challenges in the ADRD field? Let's see if my voice holds out for this. So coming back to here, I want to go back to these challenges that I mentioned and just highlight how NAC data is a really important resource for this. So as far as advancing early detection using disease biomarkers, so one of the reasons that NAC is great for this is that we have valuable longitudinal data that was collected before and after the onset of disease. We have rich multi-domain data, we have blood biomarker data, we have standard MRI and PET, and with UDSP4, we'll also have robust data on the use of disease-modifying drugs like donanemab and lecanemab. In addition to that, it's a valuable tool for being able to identify participants for current and future disease-modifying therapies. We're also working to leverage real-world data to enable early detection. I didn't have time to tell you about it today, but we have a COVID-19 administrative supplement focused on integrating EHR claims data with genetic genomic UDS data. We're also a finalist for a new U54 real-world data initiative that will be focused on collecting real-world data from up to 100% of the US population, and a lot of that will be integrated with NAC data as well. When it comes to disentangling heterogeneity, I mentioned that mixed pathologies are common. Some of those common occurring mixed pathologies are Lewy body, frontotemporal lobar degeneration, cerebrovascular disease, and late, which is caused by TDP43. And so these pure and mixed pathologies are well represented in our database. We also have PET and neuropathology data that's available for researchers to confirm the accuracy of AD diagnosis. And as I mentioned, we also have a large quantity of neuropathology data that can be used to confirm the presence of co-pathologies after patients pass away. A new thing that's coming, as I mentioned, is that with Clarity, we'll also be bringing in a large quantity of digital neuropath data. We're really excited about the potential that we'll have for driving more AI discovery. So when it comes to validating blood-based biomarkers, as I mentioned, we're going to be massively amplifying the amount of blood-based biomarker data that we're collecting from across the ADRC program with Clarity. And we'll also be combining that with neuroimaging data. We really want to be able to validate these blood-based biomarkers and understand how effective they are for and what stages they can be used, and also develop new biomarkers for other types of etiologies that underlie dementia symptoms. So PET will available as data as also will be in NAC and enables folks to be able to validate those blood biomarkers. We also have a few, NAC data is about to become a lot more valuable for being able to identify and stratify risk factors and protective mechanisms. So as I mentioned, as part of UDS v4 that we're rolling out this spring, it's going to involve mandatory collection of large quantities of social determinants of health data. So we're really excited about that and the opportunities that's going to open up to be able to enable researchers to ask and answer new questions in the SDOH space. We also have a pending grant that's focused on exposome data that we're waiting to hear about this month. With regards to precision medicine, NAC is also data is extremely valuable for this. So I mentioned that we have extremely rich phenotypic data. This is used all of the time in genetic analyses for really high impact papers. NAC data has also been instrumental in facilitating developing neurocognitive, neuropathology, and PET harmonization methods to bridge large-scale ADRD studies. A lot of that has been done through the ADSP Phenotypic Harmonization Consortium, and once again, relying on mapping to those NAC gold standards diagnoses that I mentioned. We're going to be expanding this further through the collaboration I mentioned with Sage Bionetworks. We'll be integrating multi-omics data through their AD Knowledge Portal. And we believe that the harmonized data that's being generated with our collaborators will be valuable for AI-driven discovery as well. Lastly, these are some of the active grants that I'm a part of that are underway right now here at NAC. And I'm going to end there. And thank you for your time. I can't leave my voice held out. I can't hear anyone if they're talking. Peter, are you saying something? Sorry, I can't.
You have a hand up, Sarah.
Oh,
Okay.
I can't see it, but
Can you hear me now?
yeah.
There are a couple of questions in there. Thank you very much for a great talk. There is a question from Caitlin.
Yeah.
At 11:33 and a question from Zoe at 11:36.
In the chat?
Yep.
I'm looking for it. Hold on, sorry. Trying to find it. Where can Caitlin? Okay.
You want them read to you?
I found it now. Sorry, I'm being slow. So Caitlin, you asked, do you have important lessons learned or recommendations for people working on data modernization, or improving quality and consistent EDT? I guess I do. Yeah. I think I want to go back to really emphasize again, don't build it and hope that they come. That is the key. So one of the, I think, keys to some of the success that we've had at NAC is that we really take a lot of time to understand the pain points. So I'll give you an example. Like when I first came in and was asked to like get scan going, right? Get scan working. It's not working. Get scan working. Get sites submitting data. We went and we interviewed 20 sites. We had 20 sites that received funding to submit scan data, but we weren't doing it, right? So we interviewed 20 sites to try to understand, okay, what are the pain points? Why isn't this happening? What solutions do we need to be able to build to address those pain points? And then we did extensive surveying, et cetera. That took a lot of time, but really making sure that we understood the needs and the pain points before we dove into building solutions was absolutely critical for this. And what we ended up developing were solutions that everyone is now using, right? And it's really driving, increased data submissions, as you saw from the data slides that I showed you. So I think finding out the needs and pain points before you start building, so you make sure you're addressing the right problems with your solutions, but also involving a consortium, stakeholders in the co-development, right? Create a framework where they can also get involved to help iteratively develop solutions and provide feedback along the way, because then they really feel a sense of ownership, right, with what's being built, and they want to use it because they helped make it, right? So I think those have been, I honestly think that applies to pretty much everything that we've done. So like, I'd love to have a data front door like cohort selection tool right now. I have an idea of what I think would work for it, right? But we're taking our time and building that. We're having this big workshop this summer, bringing together, 75 to 100 researchers to understand the requirements, the pain points before we jump into building that critical tool to make sure that it's going to be used by people. Does that, hopefully that answers your question. There's another question.
Yeah, a little further down from Zoe.
Excuse me. Zoe.
I can read it. Is there any resource we can learn more about the team's lessons and advice to other people working on data modernization?
Well, we're actually working on a paper on that, but it's not available today. But we'd be happy to, have discussions about it and honestly invite collaboration on all of the things that I mentioned today. Happy to talk about it with folks and think about it with folks more. We also do
I
have...
apologize for the echo. There's some issues with the Zoom room. There's a question from Fran Hu at 11:50. Two simple questions specific to MRI data. How do we locate and determine which ones to use? Is it better to use most recent image or the baseline image?
We have different kinds of MRI data that are available. So we have our heterogeneous MRI data, which is basically like send whatever you want. There's no standardization. For that, and we have some of that data longitudinally for participants. I think we have like 11,000 images like that. So that data researchers have found useful for, like some folks have gone and said, okay, we're going to build some model on this very standardized MRI data, and then we're going to test it out on this much more heterogeneous data available through that collection at NAC, right? To see, well, how does our algorithm perform in a more real world setting with this like messy heterogeneous data? Now, SCAN is what I talked to you about as far as that standardized MRI data. So MRI and PET data, that is like extremely standardized, right? All QC'd the same way. It's like extremely rigorous. So for that, we're also collecting that longitudinally. So I think it really depends on, like, there's a lot of value in having longitudinal MRI and PET data if you want to be able to track the course of someone's disease. So I would really have to talk about what particular application you want to use it for to be able to make a good recommendation about whether you should reuse the most recent scan or something previous. And please keep in mind that all of that scan data is also accompanied by lots of other data, that neurocognitive data that I mentioned, each of those scans, right? Because people are coming every year for their scans and for UDS data collection. But I'd be happy to, if you have more specific questions about it, dive in and think about it with you. Any other questions?
Sorry, I had a question. I posted it in the chat, but I thought it was a really great presentation and really impactful work. But I was wondering, about long-term maintenance of projects like this. My understanding is that they tend to require significant resources to maintain beyond deployment. So I was wondering, like for this, like for this project and others, what are the plans for maintaining the ongoing funding and support once the initial deployment funding dries up?
Yeah. Well, NAC has been around for 23 years, thanks to Walter Kukul, who is also here listening to this talk and who's a NAC director. Been around for 23 years. And yes, it does take significant resources to keep this going, especially with all of the expansions and additional modernization that we've made happen, right, over the past 2 years or so. So yeah, we have to, apply for follow-on funding. So that is something I'm gearing up the team to do that right now. We actually have our budget due, I think, tomorrow for the next 5 years of our grant, and really making a plan for how we're going to both maintain this amazing stuff that we've built, but also continue to build on it and make it even more valuable for the research community through things like that secure enclave environment I mentioned and other new tools we're planning to deploy. Hopefully that helps. Basically, writing lots of grants is the answer.
So where do those, where do those grants go to? Is it like NIH funded then, or to like Gates Foundation, or?
We're funded by NIH, primarily from the National Institute of Aging. So almost all of our funding comes through there. And it's about $50 million in funding right now. So our 5-year renewal is about a $50 million grant at this point. It's not cheap.
Great, thank you.
Yeah. I see another hand up. Jose, hi.
Yeah. Story is ahead of me.
Okay.
Oh, sorry.
Right.
I'm going to lower my hand. I already got my answer. Thank you so much.
So it's more than 50 million because every of the 37 ADRCs like mine, like ours, also has another, 10, 15, 20 million.
Yeah, that's just
great presentation, Jose Cavazos. I'm one of the, I'm the steering committee for research education of the ADRCs. And this is a terrific presentation that we would like to post for all the REC scholars. One question has to do with the delay of information and uploading. So as a clinician, as a practicing neurologist, how long does it take? For example, we just got the data sets, or I mean, we got the new drugs, the new biologics, the infusions. You know, there are many clinically significant questions like how long does this infusion needs to go? How long do we need to give boosters to remove the trash out of the amyloid and tau out of the cells? And, you know, whether the patients need to have, are there any predictors for having new drugs, et cetera, et cetera. So can you talk a little bit about how large these data sets are for the new treatments? And, you know, what is the lag time that exists between a visit, a, you know, imaging, and getting uploaded?
Yeah. Thanks so much for joining, Jose. It's good to see you. And thanks for your great question. So, yeah, so I think we're really trying to reduce that lag time. There's a couple of solutions that we have in the work, some of which have been partially deployed actually already over the past few months. So as far as like getting information back to ADRCs about their own participants, which is really critical, right? We deployed a new tool, which I didn't have time to talk about today, called the ADRC portals. And so what that allows ADRCs to do, so I talked a little about that with SCAN, how we developed these QC dashboards, so our ADRCs could get in there and like access, audit, and view the MRI and PET data for their own participants, right? And track the QC process, and if something failed QC, find out why it failed QC so they could quickly address it, right? So that's one example of that. But for things like Clarity, what we're going to be using those dashboards for to return information on like amyloid and tau PET status for each participant, right? So you can get that information right away for your participants through the ADRC dashboard, ADRC portals. So we're trying to build as many components as possible. I could pull up another slide to show this actually. That's going to enable essentially where ADRCs can go and they have their own dashboard within the NAC data platform for their data for their participants. They can see, okay, what's UDS data do I have? What's happening with my scan data submissions? What's the amyloid and tau status of my participants, right? What do their blood biomarker profiles look like? But then also things like how diverse is my ADRC? Like in real time, like let's have a real-time yardstick for like how is participation? How well am I diversifying our participant pool? Like it's all going to be available in time, right? So you have that yardstick so you can quickly track the impact of different types of new recruitment strategies, things like that. So those are, hope that answers your question. We're trying to really expedite that feedback loop of information to ADRCs about their own participants, and that ADRC portal is a really critical and exciting tool for that. So parts of that portal are available right now, like the SCAN QC dashboard, but a lot more components are coming very soon in the next few months or so.
It was very helpful for our external advisory visit yesterday.
Good, I'm glad.
So sorry to interrupt. We're at the top of the hour, so I'm going to close this meeting. Thank you so much, Sarah, for going above and beyond with your cold and your laryngitis, et cetera. So thank you so much. If other folks have questions, I believe you left your contact info. People can email you, and I'll talk to you about the recording. Thanks.
Thank you so much, everyone. Thanks for having me, Peter. Bye.